Welcome to ATCM, the Emergency Medicine Channel.
Today's topic, Chapter 5 of ATLS, Abdominal and Pelvic Trauma. The assessment of circulation during the primary survey include early evaluation for possible intra-abdominal and
What are the study
pelvic
objectives first of all?
objectives?
What all things you are going to deal in this chapter?
The objective of this chapter include anatomical region of abdomen that are critical in assessing and managing trauma patient. Second one is recognize a patient who are at risk for abdominal and pelvic injury based on mechanism of injury. Identify patients who require surgical consultation and possible surgical and catheter based interventions. Use the appropriate diagnostic procedure to determine if a patient have ongoing hemorrhage and or injuries that can cause delayed mortality and morbidity. And then is acute management of abdominal and pelvic injuries.
Okay. So anatomically you should know the parts, what all organs are beneath that area. And then
Mechanism of injury.
the mechanism of injury, we want to know what organs could be involved. Suppose it's a head-on collision or like a blunt abdominal trauma, penetrating abdominal trauma, which organ will be involved mostly? Is it spleen, liver? Which organ you should know first? Then
identify the patients who require immediate surgical consultation.
Yeah, which patient requires laparotomy? Which patient has to be referred to a surgeon? Okay.
And the diagnostic procedures.
And all the diagnostic procedures such as ultrasound, USG fast, CCT, diagnostic peritoneal lavage, things like that.
Okay. Then acute management for abdominal and pelvic injuries.
Yes, then management. So these are the headings under which you should be covering this topic. Okay.
So the assessment including primary survey should include early evaluation of possible intra-abdominal and pelvic hemorrhage in patient who has sustained a pelvic trauma. Any penetrating torsal wound that is below nipple and perineum should be considered as a potential cause for intra-abdominal hemorrhage. First, we will start with the anatomy of abdomen. Abdomen and
so in case of an abdominal trauma, this will be detected when you reach C.
Circulation.
Right? Yes. In circulation only these things, because the tenderness guarding, when you look at the abdomen, tenderness guarding rigidity. Features of peritonitis. Okay. That is where, and pelvic trauma, if there is an open book pelvic fracture, then everything is in C right now. It's not in A or B, D or E. It's in C. Okay.
So, anatomy of abdomen. Abdomen is basically enclosed by the lower thorax. It is divided into mainly 4 regions. First one is anterior abdomen, which is the area between the costal margin superiorly, inguinal ligament and pubic symphysis inferiorly, and anterior axillary line laterally. Mostly hollow viscera.
So like this.
Superiorly costal
margin, anterior axillary line, inguinal ligament, pubic symphysis, anterior abdomen. Okay.
Mostly hollow viscera are at risk if any injury to anterior abdomen occur. Next
so
one
small
is
bowel, large bowel,
things
like that. Pancreas. Okay.
Then second one is thoracoabdomen, which is an area inferior to the nipple line anteriorly, infrascapular line posteriorly, and superior to the costal margin. This area
so that means here superior to the costal margin
and the
nipple line and then anteriorly, posteriorly the infrascapular area. That area is called thoracoabdominal area. Okay.
This is because the diaphragm raises to the level of 4th intercostal space during full expiration. So if any injury at that area, mostly we are suspecting diaphragm, liver, spleen or stomach injury. Then next.
So I hope all of you know what all things are there in each part of the. Okay.
Any fracture to the lower rib or penetrating wound below nipple, these organs can get traumatized. Next one is flank. Flank is actually between anterior and posterior axillary line from the 6th intercostal space to the pubic crust.
Got it, no? Anterior axillary line, posterior axillary line,
6th intercostal
space superiorly,
pubic crust.
Crust, okay.
Then back is the area located posterior to the posterior axillary line from the tip of scapula to the iliac crest.
Got it? Posterior axillary line,
Right? Iliac
tip
crest.
of scapula superiorly,
Iliac
crest posteriorly.
posterior. So basically the musculatures in the flanks, back and paraspinal region are partially protective to the viscera. Then these flanks and back mostly contain retroperitoneal organs. So basically flank and back are retroperitoneal spaces. These are potentially the area posterior to the peritoneal line of the abdomen. The organs include abdominal aorta, inferior vena cava, duodenum, pancreas, kidney, ureter, posterior aspect of the ascending colon, descending colon, retroperitoneal components of pelvic cavity. All are found there. If any injury to the retroperitoneal structures, it is very difficult to recognize because they are deep within the abdomen and may not initially presented with signs of peritonitis. And it is very poorly visualized in fast also, so difficult to
So that's important
diagnose.
of retroperitoneal structures. Even if you do fast, you may not be able to find out. So basically anterior abdomen, thoracoabdomen,
Flank,
here.
flank,
Okay.
flank and back.
Flank and back,
Back and flank mostly contain
retroperitoneal structures. So be careful.
Then pelvic cavity is the area surrounded by the pelvic bone containing the lower part of the retroperitoneal and intraperitoneal spaces. It contains rectum, bladder, iliac vessels and female internal reproductive organ. Significant blood loss can occur from injuries to organs within the pelvis or directly from the bony pelvis. So the first topic, anatomy, is done. Next one is mechanism of injury. Basically, there are
Clear?
three types of mechanism we are saying. One is blunt, then penetrating, then blast area, blast injury. So blunt, in blunt there are direct blow, shearing injuries and decelerating injuries. So direct blow is mainly, examples are lower rim of in RTs and bicycle steering wheels get injected or motorcycle injuries. Mostly they cause deformation in the solid and hollow organ that can cause rupture with secondary hemorrhage and contamination by the visceral cavity, which leads to peritonitis. Then second one is shearing injuries, which is mostly result from this is a form of crush injury that result when a restraint device is worn inappropriately, like a seat belt is not worn properly. Or then third one is decelerating injury, that is mostly seen in RTs and also from fall from height. These are differential movement of fixed and mobile part of the body. These can cause injuries like laceration of liver and spleen. Then buccal handle injury of the bowel is also an example of deceleration injury. Then in case of blunt trauma, the most frequently injured organ is spleen, then is liver and then small intestine. Only when undergoing a laparotomy only we can find out any retroperitoneal hematoma can also occur, which mostly we seen during laparotomy. Then second one is penetrating injury. Stab wound and low energy gunshot wound causes tissue damage by laceration and tearing. High energy gunshot wound transfer more kinetic energy, causing increased damage surrounding the track of missile due to temporary cavitation. So in case of stab wound, most commonly injured organ is liver, then small intestine, then diaphragm, then colon. Gunshot wound can cause additional intra-abdominal injury based on trajectory, cavitation effect and possible bullet fragmentation. In gunshot wound, mostly injured are small bowel, colon, abdominal vascular structure. The third one is blast injury, mostly by explosive devices, which include both penetrating fragment wounds and also blunt wound. We also have to consider the possibility of combining penetrating and blunt wound with additional injury to tympanic membrane, lungs and bowel related to blast overpressure.
So basically, for MRCM, what they ask is the most complex. There are 3 injuries: blunt injury, penetrating injury, blast injury. Okay. So blunt injury, the most common organ involved is in a blunt injury is spleen. So you'll write which of the following is the most commonest organ in the case of a blunt injury: spleen, liver, small bowel, pancreas, like that. So it's a spleen. In case of penetrating injury,
stab, most common is liver.
Stab injury, most common organ involved is liver. Okay.
Gunshot, small bowel.
Yes, gunshot, small bowel. These are very frequently asked, these 3 questions. If at all they come with a question on abdominal trauma, this is the one which comes. Okay.
Then assessment and management.
Blast injury should involve, you should look for tympanic membrane,
lungs and bowel.
Okay.
Additional blast overpressure.
All right.
Assessment and management. In hypotensive patient, the goal is to rapidly identify an abdominal and pelvic injury and determine whether it is the cause of hypotension. So, in a hemodynamically normal patient without a sign of peritonitis may undergo a more detailed evaluation to determine the presence of injury that can cause delayed morbidity and mortality. So, in case of history, we should ask about the vehicles. In case of RTA, we should know about vehicle speed, type of collision, if it is a frontal impact or lateral impact or a side sweep, rear impact or rollover.
Because the mechanism of injury is important. To know which organ is probably affected. Okay.
And also whether the patient is a driver or a pavilion passenger or any type of restraints like seat belts were there or a deployment of airbag, patient's position and status of other occupants we have to look for. If in case of fall from height, we should know the height of the fall. When assessing a patient who has sustained penetrating injury, we should know the type of wound. In case of gunshot, we should know the distance from which the bullet will be coming.
Time and type of wound in penetrating.
Time of injury, type of weapon.
Type of weapon.
If it is a knife or a handgun or rifle or shotgun.
Okay.
And also the distance, because particularly important with shotgun wound, as likelihood of major visceral injury decreases beyond the 10 feet or 3 meter range. Then number of times stab or gunshot is sustained, the amount of external bleeding and everything we have to ask in history. In case of explosion, explosion can produce since visceral overpower injuries, we have to look for any breathlessness, hearing deficiency and hearing problem, hearing loss and everything also, so in history. In physical examination, we have to do a thorough examination including...
You will get short note on penetrating abdominal trauma, blunt abdominal trauma, and also bomb blast injuries. I think last time, the question was on bomb blast. So which organ is involved? When to call a surgeon, when to do laparotomy in case of blunt abdominal trauma, in case of penetrating abdominal trauma, things like that.
So then examination, we have to do inspection, auscultation, percussion and palpation. We also have to, which is followed by the examination of pelvis and buttocks as well. Then urethral, perineal and rectal and vaginal examination also to be done. Then during inspection, we have to examine the anterior and posterior abdomen as well as the lower chest and perineum for abrasions, contusions from the restraining devices, laceration, penetrating wound, impaling foreign bodies, evisceration of omentum or bowel, and also the pregnant state. Inspect the flanks, scrotum, urethral meatus, perianal area for blood, swelling, bruises, laceration of the perineum, vagina, rectum or buttocks may be associated with the open pelvic fracture in blunt trauma patient. For complete back examination, we have to log roll the patient and examine the spine area and also back for any contusions. After examination, we have to cover the patient with a warm blanket to prevent hypothermia.
Even vertebral fractures are also common in a deceleration. Like if you travel in this thing suddenly apply brake because of hyperflexion, vertebral fractures, chance fracture. Chance.
So,
Chance, which is which vertebral?
L1L.
Find out that's a.
Then when
because on all this thing that spine there are named fractures, Jefferson fracture, chance fracture, things like that. Clay shovelers fracture. Jefferson is C1, right? Clay shovelers C7. Okay. Chances find out. Okay.
On palpation, if rebound tenderness is present, we don't need to do other palpation. We have to, take the patient for laparotomy if peritonitis is there. So in pelvic examination, pelvic assessment, if in an unexplained hypotension may be the only initial indication of major pelvic disruption. Mechanical instability of the pelvic rim should be assumed in patients who have a pelvic fracture with hypotension and no other source of blood loss. Placement of a pelvic blinder is a priority and may be a life-saving in these circumstances. So on physical examination, we also have to...
so when will you apply pelvic binder in primary survey? Is it in A, B, C, D, E, F? Where is it?
Circulation. In case of hypotension and we can't find out any source of... in case of hypotension and PCT positive.
PCT positive.
Pelvic compression test. Hypotension that can't be seen, like no external injury.
If the examiner says that there is any sign of this, like if there is any perineal area hematoma or any pain in this area, suspected urethral meatus, bleed, things like that, always suspect a this thing and apply. Don't do a pelvic compression test then. Immediately apply the pelvic binder.
That in next one is that only, sir. Physical examination findings like evidence of ruptured urethra, scrotal edema or blood on the urethral meatus, discrepancy in limb length or rotated deformity of length without any obvious fracture, we have to apply. Avoid
because
manual
of an IT fracture,
manipulation.
neck-of-femur fracture, because discrepancy can happen.
In this rotated deformity
dislocation
without obvious fractures. Rotational deformity of leg without obvious fractures, we have to apply pelvic binder. But they also say avoid manual manipulation.
So it can come as a question for you guys. Pelvic binder indications. Because it's usually done in the pre-hospital area. So when to apply?
So in this patient, we have to avoid manual manipulation of pelvis. As doing so, we can dislodge a blood clot and cause further hemorrhage. We also can generally palpate the bony pelvis to look for any tenderness. Then the mechanically unstable hemipelvis migrate when there is any rotation of outwards. Because of muscular force and rotates outward to the effect of gravity on unstable hemipelvis. External rotation of an unstable pelvis result in increased pelvic volume that can also cause more bleeding. We have to stabilize pelvis with a binder or a sheet at the level of greater trochanter rather than the iliac crest.
For MCQ. At what level do you apply the pelvic binder? Okay.
Then the presence of blood at the urethral meatus strongly suggests. Then next one is urethral, perineal or rectal, vaginal, gluteal examination. Presence of blood in the urethral meatus strongly suggests urethral injury. Ecchymosis or edema, hematoma of the scrotum and perineum also suggests urethral injury. In rectal examination, we have to look for sphincter tones and rectal mucosal integrity to identify any palpable fracture, and also we have to identify. In case of a penetrating wound, in patients with penetrating wound, the rectal
So why do you do a rectal examination? That is one question. What? To assess the rectal tone.
Rectal tone.
It's not to assess this thing, prostate or anything.
Prostate.
That initially, like the previous ATLS, they told we're looking for high riding prostate. But right now, that is not the indication. Right now, the indication is just to know the sphincter tone. Okay.
And also to look for any gross blood to rule out any bowel perforation. In case of hematoma or urethral bleeding, we should not try urethral catheterization of the patient.
Because that itself is an indication for laparotomy, blood through the orifices. Got it, no? So that is why you do then and there. It will see itself, you do a PPR and go down. So you can actually in that primary survey, you can just mention that part also. In circulation, do a rectal examination. Is there any blood in my hand? In C itself. Because then and there itself is an indication for laparotomy.
If we are suspecting any complex perineal injury, pelvic fracture or transpelvic gunshot, we have to look for a vaginal examination. In an unresponsive menstrual woman, we also have to examine vagina to look for any tampons which can lead to delayed sepsis. In gluteal area,
pregnant ladies will have to do a UPT also.
UPT also.
You don't know whether we are dealing with
pregnant.
Yeah.
Then gluteal region extends from the iliac crest to the gluteal fold. Any penetrating injury to this area have 50% up to 50% incidence of significant intra-abdominal injuries, including rectal injuries below the perineal reflection. Then adjuvants to physical examination. After gastric tubes and urethral catheter, gastric tube we usually done as a therapeutic measure to relieve acute gastric dilatation and stomach decompression before performing DPL, diagnostic peritoneal lavage. These gastric tube may reduce incidence of aspiration, but in case of if the patient have a strong gag reflex, it can trigger vomiting also. The presence of blood in the gastric content suggests the injury to esophagus or upper GI tract.
So that is also indication for laparotomy. Any blood in any of the orifices, even if it is from the here orally or from the rectum. In case of severe facial fractures or basal skull fracture, we have to put the gastric tube through mouth than the nose. Then urethral catheter, it's usually to relieve retention, identify bleeding, allow for monitoring of urinary output as an index to tissue perfusion, and decompress the bladder before DPL. If fast we are considering, delay placing a urethral catheter until after the test is complete. Gross hematuria is indication for trauma to the genitourethral tract, including kidneys, urethra and bladder. In case of a disrupted urethra, we will put a suprapubic catheter and drain the fluid. So, in patients with the hemodynamic abnormality, rapid exclusion of intra-abdominal hemorrhage is necessary and can be accompanied with either fast or DPL. DPL is?
Peritoneal lavage. Patient with the following finding require further abdominal evaluation to identify or exclude intra-abdominal injuries. They are altered sensorium, altered sensation, injury to adjacent structures such as lower rib, pelvis, lumbar spine.
I didn't get it. What is it?
So if these signs are there, we need to further evaluate abdomen to to identify or exclude intra-abdominal injuries. Like if the patient is having altered sensorium, if the patient have altered sensations, injury to adjacent structures like lower rib, pelvis, lumbar spine, or equivocal physical examination, prolonged loss of contact with the patient, and also seatbelt sign that abrasion, we have to rule out other abdominal trauma. When intra-abdominal injury is suspected, if a number of studies can provide useful information. However, when indicated for patients transfer, we have to evaluate. But if it is indicated, we have to, as soon as we have to laparotomy, or we need to get a plan done as soon as possible. We can't delay in intra-abdominal trauma. Then there is a comparison between DPL fast and CECT, in which DPL is an early operative determination which can rapidly perform, can detect a bowel injury, no need to transport to area from the resuscitation area. But the disadvantages are it is invasive and risky procedure and required gastric and urinary decompression to prevent complication before the procedure. Indication of abnormal hemodynamic in blunt abdominal trauma, penetrating abdominal trauma without other indication for immediate laparotomy. Then EFAST
indications of DPL can come as a question. Blunt abdominal trauma with
penetrating abdominal trauma without other indication for immediate laparotomy. We can do
all blunt abdominal trauma should you do
hemodynamic abnormality. Abnormal hemodynamic in blunt abdominal trauma is an indication.
Fast is the next.
Next one is fast, which is a non-invasive but can perform rapidly, but we can also repeatedly perform the test. But it is operator dependent. Bowel gas and subcutaneous air can distort the images. Fast can also miss diaphragm, bowel and pancreatic injuries. Can't assess retroperitoneal structures. Then which indication is also the same, abnormal hemodynamic, but not other indication for laparotomy. CT scan we usually perform in a normal hemodynamic patient.
So any the take home message is, any unstable patient, do not shift the patient to CT room. Straight away do ultrasound. Only if the patient is stable should you be shifting the patient to for CT. Then
we could do diagnostic laparoscopy or thoracoscopy, which is done in a hemodynamically normal penetrating trauma patient with potential tangential injury and without indication of laparotomy. It is to diagnose diaphragmatic injury and perineal penetrations. Then other contrast studies include urethrophy, cystography, intravenous pyelography, gastrointestinal contrast study, and everything could be done to rule out any urethral injury or intra-abdominal or extra-abdominal bowel injury, rupture in case of cystograph, and kidney injuries in case of intravenous pyelograph, and other gastrointestinal contrast study can be ruled out to do all bowel injuries.
What are the investigations?
Urethrophy, cystography, intravenous pyelogram, gastrointestinal contrast studies.
Okay.
Then evaluation of specific penetration injuries. Indication for laparotomy. All most abdominal gunshot wounds are managed by exploratory.
This is important. Can come as a question. Okay.
Diagnostic laparoscopy is a reliable study to determine perineal or diaphragmatic penetration in thoraco-abdominal studies. Most abdominal gunshot wounds are managed by exploratory laparotomy. The incidence of significant intraperitoneal injury approaches 98% when peritoneal penetration is present. So, indication for laparotomy.
Peritoneal perforation injuries mean peritonitis will occur. There could be air under the diaphragm in X-ray.
Exactly.
Then all these things you have to operate, do a laparotomy.
So most common the indications of laparotomy in patients with penetrating abdominal wound include hemodynamic abnormality, gunshot wound with a transperitoneal trajectory, signs of peritoneal irritation, signs of peritoneal penetration. Example, evisceration.
So if the peritoneum is involved in case of penetrating injury, and if there is hypotension, or if the peritoneum is involved with peritonitis or air under the diaphragm, or if the trajectory is
in transperitoneal
trajectory of the gunshot wound, then immediate laparotomy.
Then there's other indications of laparotomy is blunt abdominal trauma with hypotension with a positive fast or clinical evidence of intraperitoneal bleeding or without another source of bleeding. Blunt trauma.
Now she is talking about blunt indications of laparotomy in blunt abdominal trauma. That is also
fast positive
blunt abdominal trauma with the fast positivity.
Fast positive.
Then hypotension.
Then clinical evidence of intraperitoneal bleeding, or if there is no other source of bleeding, you will do a laparotomy.
Okay. Clinical evidence of intraperitoneal bleeding.
Then hypotension with abdominal wound that penetrate the anterior fascia. Bleeding from the stomach, rectum, genitourinary tract after penetrating trauma. Free air, retroperitoneal air or rupture of hemidiaphragm. Contrast enhanced CT that demonstrate ruptured gastrointestinal tract, intraperitoneal bladder injury, renal pedicle injury, or severe visceral parenchymal injury after blunt or penetrating trauma.
That is after CT.
After CT.
Okay. One is before CT.
Before CT.
Two options: penetrating injury, indications for laparotomy, then blunt abdominal trauma.
With the hypotension.
That is before CT. After CT, again some more indications will come into this thing.
Then blunt or penetrating injury, while doing DPL, we get aspiration of gastric content or vegetable fibers or bile, or aspiration of 110 cc or more of blood. In a hemodynamic abnormal patient, we will do a laparotomy. After DPL.
Okay, once more.
After DPL, if we get any abdominal gastrointestinal content or bile or vegetable fibers or 10 cc or more blood in a hemodynamic abnormal patient.
So all these things such as perforation, you are actually doing a diagnostic peritoneal lavage. No? You are seeing for all these this extravascular like blood or this thing, gastric materials and all in the abdomen. So it all suggests perforation. That's why it's directly an indication for laparotomy. So you don't do it here, DPL.
In next one is evaluation of other specific injuries. Then liver, spleen, kidneys are the organs predominantly involved in a blunt trauma. Diaphragm injury, blunt injury can occur in any portion on either diaphragm, although the left hemidiaphragm is more often injured. The signs in initial X-ray include elevation or blurring of the hemidiaphragm, hemothorax or abnormal gas shadow that obscure the hemidiaphragm or gastric tube placed in the chest. Then in duodenal injury is most commonly seen in RTs. We have to do a double contrast CT or emergent laparotomy in a high risk patient. Duodenal injury. Pancreatic injury, mostly from a direct epigastric blow that compresses the pancreas against the vertebral column. An early normal serum amylase does not exclude major pancreatic trauma, but amylase level can also be increased in non-pancreatic sources.
Okay.
Then in case of contusion, hematoma, ecchymosis of the flanks and back are markers of potential underlying renal injury, and further evaluation including CT and intravenous pyelogram is needed. Gross hematuria is an indication for imaging of the urethral tract. gross hematuria and microscopic hematuria in patient with episode of shock are markers for increased risk of renal abdominal injury. Anterior pelvic fracture usually is present in patient with urethral injuries. Urethral disruptions are divided into those above and below the urogenital diaphragm. Posterior urethral injury is usually associated with multi-system injuries and pelvic fractures, whereas anterior urethric injury, that is below the urogenital diaphragm, results from the straddle impact and can be an isolated injury. Then, in case of hollow viscous injuries, blunt injury to intestine, usually following a sudden deceleration with the subsequent tearing near a fixed point of attachment. A transverse linear ecchymosis in the anterior wall, which is called seatbelt sign, or a lumbar distraction fracture, we have to rule out intestinal injuries. Although some patients have early abdominal pain and tenderness, hollow injury can be difficult to diagnose since they are mostly not associated with hemorrhage. Other solid injuries, solid organ injuries, like in liver, spleen, and kidney, can result in shock, hemodynamic abnormality, and evidence of continuous hemorrhage, and are indication for urgent laparotomy. Then, pelvic fractures are patients with hypotension and pelvic fracture have a high mortality. Pelvic fractures are associated with hemorrhage, commonly involve disruption of the posterior osseous ligament complex, that is sacroiliac, sacrospinous, sacrotuberous, and fibromuscular pelvic floor, evidenced by a sacral fracture or sacroiliac fracture and dislocation of sacral iliac joint. So basically, this pelvic fracture is classified into 4 types based on the injury force pattern, which are AP, anteroposterior compression.
Pelvic fracture classification is one question.
Anteroposterior compression.
My final year exam, I had a question on pelvic fractures, essay question.
Then anteroposterior compression, lateral injury, vertical injury, and combined injury. In case of anteroposterior compression, mostly associated with motorcycle or head-on motor vehicle clash, it produces external rotation of the heavy pelvis with separation of the pubic symphysis and tearing of the posterior ligamentous complex. This disrupted pelvic rim widens, tearing the posterior venous plexus and branches of the internal iliac artery system. Thus, hemorrhage is very severe and life-threatening in the anterior.
So, pelvic venous plexus injury is the cause for
hemorrhage.
Hemorrhage in the case of
pelvic fracture.
Pelvic trauma.
In case of lateral compression injury, the force will be directly lateral into the pelvis. Most common is RTA only, but the hemipelvis will rotate internally during lateral compression, reduces the pelvic volume, reduces the tension on the pelvic visceral structures. This internal rotation may drive the pubis into the lower genitourethral system, potentially causing injury to bladder and urethra. When this occurs, the patient required early hemorrhage control techniques such as angioembolization. In case of fragile
angioembolization is indicated in
lateral compression injury. Elderly and fragile people are more chance of. Sorry, sir.
Yeah, continue.
Elderly and fragile patients are more chance for bleeding in lateral compression. In vertical displacement of the sacroiliac joint can also disrupt the iliac vasculature and cause hemorrhage. In this mechanism, a high energy sharing force occur along the vertical plane across the anterior and the posterior aspect of the ring. This vertical shearing disrupts the sacrospinous and sacrotuberous ligament, leading to major pelvic instability. A fall from height is most common example of vertical shear injury. These Pelvic fracture hemorrhage is one of the major potential reversible fracture contributing to mortality in case of pelvic.
So anteroposterior from the
lateral aspect
vertical shear.
Then combined.
Combined.
Then management.
Is there a name of the classification or anything?
It's not written here.
Young's. Okay.
Then management. Initial management include management of hypovolemic shock associated with major pelvic disruption.
Where is Gardner's classification used for?
Gardner's.
Gardner's or Gardens?
Gardens.
Gardner's is something else. Okay. Continue.
Management include rapid hemorrhage control and fluid resuscitation. Hemorrhage is control is achieved through mechanical stabilization of the pelvic rim and external compression, external counter pressure like pelvic binders and sheets. Pelvic injury is mostly associated with a major hemorrhage externally. Major hemorrhage due to external rotation of the pelvis. So the internal rotation of the lower limb.
Was asked to for his final exam. He was asked to do pelvic binder application. He was not given the pelvic binder. He was given a bed sheet. So expect such questions.
Now we have to internally rotate the lower limbs by which in turn can reduce the pelvic volume. By applying a support directly to the patient pelvis, clinician can splint the disrupted pelvis and can reduce the potential hemorrhage. Sheet and binders.
Internal rotation of.
Internally rotate. Like in case of anterior AP compression, external rotation is the most common cause of hemorrhage. So internally rotate the pelvis, we can reduce the volume of the pelvis and in turn reduce the hemorrhage. But this it is only a temporary measure. Permanently, we have to we have to angioembolize or we have to contain the source of hemorrhage permanently.
That's done by the vascular surgeon.
So basically in management algorithm, initial management we have to do by fluid resuscitation and hypovolemic shock resuscitation. Then we have to give a surgical consult and application of pelvic wrap or binder. Then in case of intraperitoneal blood, we are suspecting if intraperitoneal blood is there, we have to go for laparotomy. If by using FAST or DPL, we can get an intraperitoneal blood. If it is present, laparotomy. If it is not there, we have to do a pre-peritoneal packing and then go for laparotomy, or we can do
by surgeon, not by the ER physicians. Okay.
And hemorrhage control fixation device should be done to control the hemorrhage. So
that's all. So basically, the entire thing lies in circulation. Plays the shock treatment, shock management. We have already dealt in the previous thing. Then indications for FAST, DPL, CT abdomen. Indications for the common organs involved in various penetrating blunt or blast injuries, and the indications for laparotomy in blunt and penetrating injuries. Indications for shifting to CT, and post CT. What are the indications for laparotomy? Before CT and after CT.
Then management
and
from ER side.
Management from ER side. Okay, anything you want to ask?